Everybody. Good afternoon. And for those online, good evening, good morning. Depends. I just want to make sure with Robin, how many people we have online, Robin? Many. So she's counting one by one. Yeah, okay. How many? Sorry? 21 so far, okay, and the people are logging in. So thank you very much for joining us today. My name is Carolina Batista. I'm a physician, and I'm the head of Global Health Affairs at Baraka, and it's a big, big pleasure to have you all here. It's been a busy week for all, right? So WHA, many meetings, many side events, a lot of learning, I'm sure, a lot of exchange. I've learned so much this week, and I've shared a lot of things, so I think I need a week break just to group and to digest everything that I've learned and memorize everything that, all the people I've met and everything that I've learned this week. So welcome again. We're very excited for this session. I think after the WHA, I think it's pretty clear there were many different agendas and priorities by different people attending this week, the world global health leaders, but there was one common theme that really was like the common thread that connected everyone, right? And whether you're working with HIV, pediatrics, NCDs, antibiotic resistance, partnerships, everyone agreed on one thing, and that's the needs to mobilize private capital for global health. If we don't, we're in big trouble, and I think that's the purpose of everyone here today, is really to learn, to share, and to hear from global champions working and really doing amazing things on it. So about Baraka, we are catalyzing private sector, private capital for global health innovation, and that's how we try to approach things, the companies we work with, and you'll be having a little taste of the types of companies that we work with today. Well, I'm a physician myself, so I always try to think of the patients I've seen in my life and how their journeys were successful or how painful they were, and that's how I try to think, and that's how we approach companies that we onboard in our portfolio, and we have a lot of them. And then we really try to go from prevention to detection to diagnosis, treatment, and end-of-life care. And I think if there was one big, big lesson of the very painful COVID pandemic that we're still kind of going through in a different phase, it's that prevention and taking care of people before they get sick and really preparing health systems, but also paying to strengthen health systems and investing in them is better than dealing with the consequences thereafter. So that's how we focus, and of course we put a lot of emphasis on data flow, of course, seamless data collection, data analysis, but also transforming all of this data, and we're going to be hearing a lot of about the data that's being collected by the entrepreneurs today and from the other speakers on how to transform data in very good, useful, and effective health information to take decisions. And then, of course, supply chain, but also how can we ensure financial protection to the people who are, getting the impact of the companies that we're working with. Because as I've seen many, many times in my career, poor people are always one medical emergency away from financial ruin and from extreme poverty. So there's definitely urgency in addressing that, and that's one of the focus we do. We always like to show the slide as who is Baraka and why we exist, right? Why am I here? After many years doing things with MSF, Doctors Without Borders, DNDi, why am I here now working with private capital for global health? And I think this slide is the reason that every day I wake up and I think, okay, I'm doing good, and I'm really doing something that's meaningful. So we have a pipeline of 280 plus companies that are already successful. They have 1 to 5 years of operation. They are raising between $1 to $20 million, and they're really addressing a lot of the patients that I've seen in my life, and I could not help because these companies didn't exist back in the days. And Baraka is a social enterprise, and we really have the vision to drive sustainable health transformation in low-middle-income countries and in emerging economies. And we have a network of a lot of investors, so I'm sure there will be a lot of networking after here during the apéro, but also online. There are a lot of people joining online. But then we have the Health Investment Intelligence Dashboards that really is our tool, is our proprietary tool that we are very happy to be now working on a pilot phase, and we received a generous grant from Johnson & Johnson Foundation. And the idea is really to do this pilot and show how all of this data, third-party data on development indicators, rural access, financial indicators, global health burden. I mean, I love global health data, and as does my team, but we have to combine them with different types of data to make sure that investors will look at the opportunities and they will understand where their investments will make an impact and to whom, and how those communities will benefit from that. So without further ado, I would love to now invite our dear colleague Sejal Singh. She's our senior financial associate, and she's joining us from New York.
Dashboard by Baraka Advanced Finance. What you see here is a brief investor where the investor can upload their investment thesis, details about their team, their past investments, industry partners, and impact focus. This profile is visible to other users on the platform. As an investor, from your profile, you can go onto the Discover tab at top to view all the active opportunities listed on the platform. In this case, the investor can apply specific filters that meets the investment criteria to get a short list. We see 6 opportunities that meets the requirements of this particular investor, and I can click on an enterprise profile to just go onto the profile page. When I click on the latent profile, I see the company's profile. The info page gives a brief about the company, a short video about their story, some operational details and highlights. We have a dedicated section that talks about the impact mission of the company and their SDG alignment. We have a specific tab that covers the current opportunity. It breaks it down to give details about the purpose of the raise, the timeline, the gap versus the committed capital, and the use of funds. We also have a diligence tab, which is for investors to collaborate with each other, conduct joint due diligence. Baraka also pre-populates this tab with its own curated due diligence template that covers the basic business preliminary information across various sections of the company for interested investors to use in their review process. Our due diligence template includes anywhere between 50 to 60 questions that are pre-populated when an investor joins the platform. Lastly, we have the intelligence tab, which gives a lot more information about the company at a macro level and on the data and the underlying impact that the company is making for an investor to truly understand why investment in this company is needed to amplify the impact that it's making. And for that purpose, we'll go to the data analytics tool. Baraka has partnered with IHME, World Bank, and the UNDP SDG Finance Hub to bring this data curation onto the platform. It will be integrated onto the intelligence tab. And as you see here, for various countries, we will have data that's populated. It shows comparative data to any developing market. It shows the regional data. We have selected 20 indicators, health indicators across the companies that will be showcased on the platform to show the health impact in the region and in the sector that the company is making. Each enterprise profile will have anywhere between 8 to 10 graphs present on the intelligence tab, and they are all interactive. We will also be able to bring some commentary that is curated by the Baraka team, along with these graphs, to give a better understanding to a reader who might not come from a health background to understand what exactly is happening in the sector where the company is operating. Along with that, we will also be able to provide some regional information and policy information in the region where the company is operating that will all facilitate a better understanding for investors when they're reviewing a particular company for an investment opportunity. Thank you very much for listening, and I'll hand over now to James.
Right? Probably. How's that? Is that better? Is that better? Okay, great. All right. So we're going to move into this program, and let me tell you at a really high level what we're trying to do. You've read the description of what we want to accomplish here, and that is to try to get into more of the nuts and bolts and the nitty-gritty that is driving what private capital is successfully being allocated to health innovation in emerging markets, and what the hurdles are that are holding up a bigger flow. I think the next slide is something that with this crowd, I don't need to spend a lot of time on. We all understand it's a huge funding gap. Hector Portale, who'll be joining us slowly, I just was on your Movement Health Foundation website today, and I noticed another figure you're using a much larger figure, a $600 and something billion annual figure. So I want to talk to you about that. It doesn't matter. Either way, we are way short of where we need to be. And it's not going to happen with public funding in our collective lifetimes. So it is about mobilizing private capital if we're going to reach those SDG 3. And you know what? I can let the SDG 3 2030 targets go, but we still have just a huge amount of work to do. There are too many underserved people, and private capital is a solution. I attended lots of sessions like I think other people did here today. I don't know how many of you were at the WHO Council Economics. This was the most inspiring session, really, of all of them. I think Mariana Mazzucato, you know, I'm going to give her a Nobel. She's just an amazing leader. And she's put together with a council of all women, by the way, an all-female council, has put together an amazing manifesto to alter the way that we think about health from a policy perspective, from a social perspective, from a human perspective. Nothing in this tome that they've produced is wrong, in my opinion. I get very excited by this vision. The problem is there are just tremendous changes in attitudes and policies and paradigms that will have to occur before the kind of realignment that's envisioned with this document can happen. More to the point in what we're all here to talk about today is this really impressive document that came out from the Investors for Health. How many of you are familiar with the Investors for Health? So I put this down so I wouldn't get it wrong. Dahlberg and the British Invest International and IFC, Quadria Capital, and Alta Semper put this document together in the first quarter of last year. And it really drives home some important truths that I think should motivate all of us on the work that we're here to talk about today. So it's increasingly obvious that there is commercial opportunity in addressing the unmet needs of communities in underserved markets. The expanding consumer base, which we all, I think, understand in low and middle income countries in particular, means that there is margin in order to begin to address need. And this is where opportunity lies from a commercial perspective. So let me pause there because there's something I wanted to say that maybe I don't need to, and I think because I've been in healthcare my whole career, and I'm there because I care about people. I'm there because I care about change. And I have a lot of opinions about how healthcare is kept human and how we do it right and how we reach the underserved. And I sense that most of the people in this room share that kind of commitment. Unfortunately, to get the private capital going that we need to really meet those needs and achieve those visions, we're going to have to look at commercial return, and that's a lot of what this discussion is about today. So I really applaud what Investors for Health put together here in terms of perspectives. They did a survey, which is the underpinning of this document, talking about growth in LMICs and what that can mean to commercial potential. So, and a point here, which I think, there are a number of African, Latin American, and Asian representatives here today who can vouch for the fact that a great portion of the healthcare being delivered today in sub-Saharan Africa, in Asia, in Latin America, is already through the private sector. The private sector is, whether it is fully integrated, whether it is properly integrated with public health or not, there is a significant private force that is driving improvements in healthcare, and we need to tap into that and begin to integrate it. That's kind of the big picture setting for the discussion that we're going to have today. And to keep us grounded in reality, we've decided to start with 4 founders, 2 companies that we work with actively, and 2 other companies we would love to be working with in the near future. And I think one kind of common feature to tell you about these particular companies is I'll ask each of them to tell you how long they've been in business. But it's all in excess of 5, 6, 7, and 10 years. And that's significant. They're veterans in running their own business. They have market traction. They have external financing already behind them, and they're looking to their next round. And it's those perspectives that I wanted all of you to hear, and that I want our panel of experts here to respond to, because these people have been in the trenches in trying to keep their businesses up and running and scaling. That's the story we want to tell today. The other thing, before I turn over to our first founder today, is to tell you that these people deserve a lot more time to tell their story. Describing the model, the traction, the social impact takes more than the 6 minutes that we've given each of them today. What I've asked them to do as a favor to all of you and to us is to tell their financial journey. So they will high-level their model, they'll high-level their social impact, and then they will move in to talk about the challenges and the successes they've had with raising capital and running their businesses successfully. So I'm going to start with Abimbola Adibakan. Did I do that okay?
All right.
All right. From Advantage, CEO of Advantage Health Africa. Thank you, Abby.
You have
The clicker's used.
Hello, everyone. So Advantage Health Africa started January 2017. So we've been at this for over 6 years. And our view is to address access issues, access, affordability, and quality of medicines. I'm a pharmacist by background, but for some reason I'd worked in management consulting. And so I came back with, I can do all things. Right. The reality is that we have done quite a bit of stuff. Now, we have a model that it's a hybrid. So we've got the direct-to-consumer, getting medicines right to the last mile, into the hands of people at home, in their offices, and sometimes they're in the hospital and there's no inventory. We bring it to them so that they can get medicines. We also have a pharma distribution arm where we distribute medicines that have been allocated to us sort of exclusively. And now, more recently, with our pharmacy management support that we're giving to over 1,000 pharmacies, we build technology to now integrate them better, and we can be that aggregator that we've always dreamed to be. As James said, I can't spend too long on the model, but every year we have grown, we have increased, we have added innovation, we have moved, we've pivoted, we've found where we want to be, and now we are indeed more established and more settled. We're in a funding round currently, but I just thought it was important to share with you how far we've come. for the first 3 years as a single female entrepreneur, bootstrapping. I could see over the river, the kind of things, oh, thank you, that I wanted, the kind of organization I wanted to build. But bootstrapping, and then eventually, just before COVID, we raised. We did not know COVID was coming. But it proved our model when CNN carried out who are the ones who are doing great things during COVID, and they could find us on ground making medicines happen at the last mile. And then we raised the $1.2 million in Naira equivalent through angel investors, local angel investors. It was new for them. And then an institutional investor also backed that up. And then we've accessed debt at different levels, paid back, accessed, paid back. I asked my finance yesterday, please add up everything. I want to put it on the slide. And it came to about $1 million. We've also been very fortunate to get grants. And I say fortunate because we didn't quite think of that aspect of our business. We are a social innovator. And the very first company that, identified me, was Bayer Foundation. So I'm eternally grateful to Bayer Foundation for the award that we got in 2021. And from then on, we've also received several others. And up until today, we got a confirmation of 100,000 euros. So that adds up to about $280,000. We're in a Series A raise for $3.2 million. And hopefully the agreement that the lawyers have finally, sent to me today would finalize, and by June we can have a drawdown. So that has, been the summary. That's the summary of the journey. But what are the challenges? First is getting to speak to the right people with a frame of mind regarding the hybrid model that we have. Some want to speak to a tech company. Some want to speak to a pharma company. We've got a hybrid, and then we've added aggregation. The aggregation almost looks like a thankless job, but you see, you need soft infrastructure in place to catalyze several other things. And therefore, if you don't find it in an environment like Nigeria, where we operate in many parts of Africa, you have to build it yourself. So that insight is needed for a lot of investors to know what we are doing. The second is the discussions are so prolonged, so, stretched out. We know that investors want to make sure that they're investing in the right vehicles and with the right team. But we also understand that some of these processes can be sped up and probably, just catalyzed. So we've been at this particular discussion for 18 months. What we assumed then, before a lot of devaluation, a lot of inflation, it's moved on. So the amount we started talking about, ideally, we should be talking 2-3 times that amount presently, but we're still at this. So some of these discussions need to, they need to speed up. So we've also we're contending with sharp devaluation of the naira. So if I got $1 million in 2019, today in naira value, it's gone like half of that amount, and you need more than double. And then there's over 20% inflationary challenges that everyone is contending with. The fourth, which I know a lot of investors seem to think is a bright idea, isn't such a bright idea for us as entrepreneurs, and that's going to the bank. So an investor will say, I want to invest $1 billion or $1 million, and they channel it through banks. Unfortunately, the banks only speak the language of asset-heavy companies. I'm an asset-light company, so I can be nimble and I can move fast. And then you're asking for collateral. What is the collateral I need to bring? A house, land. I don't have that. I don't need that to operate. So they're still far behind with unfriendly terms for companies that are structured like ours. And so if you think you're comfortable putting your money through banks, they're sitting on that money. They can't find us to take it. Every week, I get an email, I get calls, I'm like, oh, somebody's coming to meet you, Ma, we want to give you money. I said, I don't need your kind of money. So it leaves a lot of conversations inconclusive despite the availability of funding. We just do not relate with the terms at which they're coming. And for some of those, that $1 million I told you about, we've had to access them at very high rates. These rates are not sustainable. We need single-digit funding that can come to us, fund our operations in the manner that we need it, and hopefully can move things forward. Opportunities still exist. And we are indeed seeing that we need to build that ecosystem. We've got over 1,000 pharmacies in our network. Over the next 3 years, we're putting the software to power them. It's not just their point of sale, but it's a business intelligence tool for them, so they can grow. When they grow, they can serve more big pharma and mid-pharma companies. So we're looking to we built the technology, is now to deploy. If you think about what has happened in Indonesia and several other countries with how they've deployed software to power pharmacies, that's the kind of thing we're doing, if you maybe know about Swipe RX. So it will enable deployment and successful uptake by the owners and their managers. They know they need help, but there's a reluctance and a rewiring that needs to happen, and we've built that relationship for the past 6 years. We now want to take it to the next level. Final point, we now know that the data that comes out of 1 million patients every month is useful data for pharma companies, for suppliers, for funders, for public health, and also for health tech innovators that leverage ours to get to the last mile. Thank you very much.
Excellent, thank you so much. So I'm going to ask everyone to kind of watch the themes, this protracted raise period, and what a problem that makes for business planning is a common theme that you'll hear from everybody. Those unfavorable terms from local banks is another really common theme. Really inspiring. The other thing that happens for the Baraka team is we meet so many interesting and inspiring entrepreneurs, including those today, and I always want to walk away and invest, and I don't have any money. So, but I'm sure it's a good investment, so really very well done, thank you. So I'm going to turn it over now, another part of the world, to Argentina and Mexico, where Mamotest has active operations. Guillermo's become a good friend, personally, and of the company, and has a great story to tell. So I'll just leave it to you,
Thank you very much, James. Hello, everyone. Here, right? Well, as James said, I'm Guillermo Pepe. I'm the founder and CEO of Mamotest. Mamotest is a collaborative platform that is based on AI that is democratizing access to breast cancer early diagnosis while providing a pathway to treatment. Thank you, the Baraka team, for the invitation today and for the opportunity to share with you our journey. Our journey starts 10 years ago, and it starts with a conversation with my father. My father is a medical doctor specializing on breast imaging diagnosis. This conversation was held in Argentina. During that conversation, he told me about the dramatic situation with breast cancer globally. Breast cancer is the #1 cancer in the world. 700,000 women die every year because of breast cancer. And this is mainly because of late diagnosis, right? So together with my father, when he told me about this, we started doing a research on why that was happening, why women couldn't get early diagnosis. We found out that there were many barriers that were separating women from having that access. So we decided to put a solution in place. And our solution was to build the first telemammography network in Latin America. What we would do is install digital mammography units in underserved areas, and then start running awareness campaigns, pushing for legislation, so women would get to a mammogram yearly. The problem was we found out that there were no healthcare funds in order to get initial funding for that telemammography network. The economic situation or conditions in Argentina were really harsh, high inflation rates. We are speaking about maybe around 100% yearly. High taxation, no credits available. So we had to invest our own money. Besides investing our own money, we decided to start an NGO on the side so we could get additional funding to give away mammograms and at the same time push for legislation. We managed to pass laws in several provinces in the north of Argentina so women could get a day off of work in order to visit a gynecologist and have a mammogram done. 5 years later, in 2018, after having enough track record and showing the world that we're doing a good job at breaking down the barriers that were separating women from having access to early diagnosis, we managed to get our first contract with the government in one province in the north of Argentina. We also happened to get a loan from a public healthcare insurance in Argentina of $1 million in order to acquire mammography units and install a provincial telemammography network, also in another province in the north of Argentina. At the same time, we got to an agreement with a local vendor of mammography units in order to acquire them without initial disbursement. So we would pay on a pay-per-use basis. And I'm telling you about this because this is really strange to find in Argentina. It was really difficult to get these kind of deals with government, healthcare insurance, and even local vendors because there is no credit or leasing for mammography units. But so this situation was Disney to us. We were doing so great, but reality checked in 2020, pandemic. So we had to close down our mammography facilities for a while, and we started to look for different business models in order to try to sort out that situation. There were good news and bad news, like always. Good news were that overnight, telemedicine became something that started to be accepted widely. Before that, as you know, healthcare was lagging behind every other industry in terms of technology adoption. After 2020, everything changed. But still the bad news were no funding available in the region for healthcare businesses. So in order to implement our new business model, we have to go outside the region and get funds from companies in the US. So we had our seed round in 2021. It was led by Merck. It was Merck's direct investment, first direct investment worldwide, and this was because they usually invest in funds that then invest in companies, but in Latin America they couldn't find any fund to invest in, so they invested directly in us. With those funds, we happened to expand to Mexico. We started servicing companies in Spain for telediagnosis. We started building our own proprietary software for patient follow-up, Boulder, it's the name. And this year, we closed our pre-series A of 3.3 million. It was led by Johnson & Johnson, thanks to Baraka that introduced us to Johnson & Johnson. We happen to develop a 100% assetless business model. We don't install mammography units anymore. We develop that software that get connected to already existing mammography facilities, and then does the patient follow-up. We drastically changed our revenue streams. It used to be just diagnosis. Now it's diagnosis and data. So we have the Connect business model where we connect to clinics and hospitals, public and private, and we generate demand for them. We also do the patient support for them. Then we offer telediagnosis services. And with pharma, we are working on real-world data and business intelligence. We have impacted 700,000 women so far. We have reached them with mammographies. We are the first platform to have 100% traceability of the patient journey. Imagine all the data we are gathering during all that patient journey. And 87% of our patients got to a treatment on time. We have raised so far $5 million. Our main investors are Johnson & Johnson and Merck. During those 10 years, we were recognized and awarded by American College of Radiology, Sayed Sustainability Prize, United Nations, Norsken Foundation. Fast Company named us one of the top 10 most innovative companies in Latin America this year, and we are a tech partner to the World Economic Forum. So defeating breast cancer, as we know, it's in our hand. So join us and change the lives of millions of women. Thank you.
Thanks, Guillermo. Excellent. Yeah, so the other theme that I think is really interesting that you'll hear more and more about is as these companies have grown, the data they collect becomes another asset. I don't know that we're going to have enough time to cover that topic as well, but it is a really consistent phenomenon with many of the companies that we work with. We're on time, maybe about 5 minutes, and I'm going to have you stand up later, not now, just so that we keep the energy flowing in the room, because I know it's difficult at the end of a long week. But next we're going to move on to our third entrepreneur. That's Daisy Isayaho from Zuri Health. Daisy. They'll tell you where you're fine. You're good.
Hola. Hello, everyone. My name is Daisy Isiaho. I am the co-founder and chief product officer at Zuri Health. And the journey of Zuri Health started about 2 years ago at the peak of COVID-19 with the aim to democratize access to healthcare in Africa. And this is because millions of people in Africa do not have access to basic affordable healthcare. And the most affected are people living in the rural and underserved communities. So that is over 600 million people. And we also see a very painful doctor-to-patient ratio of 1 to 10,000 people, meaning that even if you can afford healthcare, there's simply not enough doctors or facilities available. Talk about when you tell people you want to provide a solution, if you cannot solve the affordability aspect, we see that the insurance penetration rate is painful as low as 2%. So many people are actually, one chronic condition away from bankruptcy. So what did we do? In our mission to provide the best universal health experience on demand, we built variable solutions to be able to solve this problem. On one hand, a virtual hospital comprising of an app, a website, and a chatbot functionality where people can be able to chat and consult with a doctor, buy medication from a pharmacy, book labs and diagnostic tests, and even have a doctor visit them at home. We call it your virtual hospital. But in order to deepen inclusion, and considering that 65% of the mobile phone users in Africa don't have access to smartphones, we also added the SMS functionality that allows patients in the rural and underserved areas chat and consult with a doctor via SMS text, and the cost is extremely low, from as low as 10 US cents, cheaper than you going to the nearest health facility to be able to get some form of basic health care and daily health tips. So this roughly is the model. We've incorporated various multiple channels and plugged in an all-round end-to-end SMS customer journey, from pharmacy delivery, telemed consultation, lab testing, and awareness. Yes, so I'm sure you're wondering how we make money. So we have multiple revenue streams because we understand running a health tech platform or company in Africa is highly fragmented. So we've plugged in multiple revenue streams, from SMS billing for customers who chat with a doctor on SMS text, to commissions from pharmacy and lab orders, because we plug in partners, pharmacy partners, including My Medicine, who are one of our key partners in Nigeria, and lab testing. So this, we're able to collaborate and provide very affordable costs. So who are our target markets? So we have two key target markets. For the SMS service, they are usually the younger and insured clients who live primarily in the rural areas. And for the app platform, these are usually the middle-income clients seeking convenience and living in urban cities like Nairobi, Lagos, and Cape Town. What is our advantage? Currently, we've been able to build an end-to-end patient journey that makes it easy for people to start and end their journey. And we have seen a very significant scale. We are the fastest growing company on the continent. We only launched 2 years ago, and we are currently live in 8 African markets. We've also seen a very high impact, because what we've been able to do is to serve the marginalized communities who are not able to access this form of healthcare. And we have very strong telco partnerships, which gives us a distribution power. We understand that, VAS is a very key market in Africa, and everyone who has a mobile phone, because we've enabled M-Pesa, mobile money, and M-Pesa wallet payment billing. At least each household has a mobile phone. So this is how we are able to actually disrupt with a very unique platform that is adaptable to harsh regulatory frameworks and also multilingual and multi-channel. So these are the key markets. We are currently live in Kenya, Nigeria, Zambia, Senegal, Tanzania, Ghana, South Africa, and Uganda. And by the end of this year, we expect to grow and expand to 20 more markets. So this is our early traction. We were able to generate over 300K on the first year of operations and did a 3x by the end of last year. Currently, we've seen cumulative GMV of over 1.2, and we work with a lot of distribution partners from pharmacy, lab insurance. We work with qualified doctors. We've seen a lot of interactions from our chatbot, and we've also have massive SMS subscribers that we get in through our partnership with telcos. So we recently closed a group framework agreement with MTN that gives us access to over 21 countries that are currently live, and this gives us also access to a subscriber base over 180 million. So this is how we are able to actually disrupt healthcare access in Africa. And in terms of the impact, we've been able to, provide first-level medical consultation to over 1 million users in Africa. We've also created decent employment and also signed partnerships with key people. So we are actively contributing to the Sustainable Development Goals. And this is our financial history. So we were able to close our pre-seed round last year in February, 1.3 through safe and convertible notes by notable VCs that were able to back us. But it was not an easy journey because it only took the first investor to back us up. That's when we got, a confirmation from the rest to come on board. And we've also been able to receive grants from notable foundations, Bayer Foundation as well, Bill and Melinda Johnson & Johnson, and DG as well. And we're currently looking to raise funds to fuel growth, sustain and improve operations to become, to be able to launch new products from Continuous Care, which is an insure lending platform for users. What are the challenges? We've actually been able to, we have limited access to capital because initially when we were speaking to investors, not many people knew about, investing in health tech. How health tech products were built previously was surviving on grant funding. But what we're able to do is to build a very sustainable business model, and how we built it was to be able to generate revenue from day one. But because, people feel like, okay, maybe my interest is not in health, or there's no high return in health, there was that, people having the risk aversion. And also we face the challenge of valuation. Some people consider we are highly valuated, we valuate ourselves low, or we have, model complexities. But when you're talking about health, you really have to be really innovative. It's only when COVID happened that it exposed the underbelly of the healthcare challenges, and now people saw the need to be able to invest in the health tech solutions. We also see a lot of, hurdles from regulatory, because in my goal to expand in multiple markets, sometimes we see that it is either highly regulated or under-regulated. For example, just for me to get a telemed license in Kenya, I had to set up a level 2 hospital just to be able to run this service. And in some markets, I have to, partner with key hospitals just to get a framework or a telemedicine license. And we also have, limited corporate structure options. When we talk to investors, they have to ask questions about where you're incorporated. Sometimes they can deny you funds just because you only have incorporated in such specific markets. So we had to incorporate our company in Delaware to actually access funds from various investors. So this is one of the hurdles that we faced. And so what is our mission? We are looking to, expand our markets beyond the urban areas and multiple markets. We are looking at ways to still diversify our revenue, working with key partners, and looking to actually close our seed round of 4 million and collaborate with more key players in the ecosystem. So these are some of the awards and achievements we've been able to be recognized. I think we are the most awarded health tech company on the continent. And yes, and so what I advise you is to join me on this journey towards democratizing access to healthcare in Africa. And please do not be scared to invest in health tech. This is a huge market opportunity around healthcare services. Thank you.
Thank you, Daisy. Really impressive. Thank you. Yeah, and another theme is the multiple forms of financing that these companies have to continue to depend on. So that whole choice about continuing to receive grants while you've got equity funders and debt funders, it's the reality, and it's the reality ongoing, not just during their early days, but as they continue to scale. And that's complex as a business leader. Okay, we have one other company that we'd like to hear from today, Reach 52, most active in Asia, but also with some African activity. Logan Ansel, it's yours.
Thanks so much, James. Appreciate it. And thanks to everyone for spending your Friday afternoon, Friday evening with us today. It's a real honor to be on the stage today. Real privilege to have the opportunity to chat about Reach 52. My name is Logan Ansel. I'm Director of Partnerships with Reach 52. I'm sort of the odd one out in this group in that I'm not the founder of the organization, but I've been with it for a number of years and happy to sort of walk you through our journey. So what is Reach 52? So Reach 52, we're a health tech social enterprise headquartered in Singapore. We describe ourselves as being an insights platform mobilizing private capital into impact-focused campaigns through networks of local agents. So what does that really look like in practice? So Reach 52, we've built an end-to-end platform. We work with cadres of community health workers, digitizing them with Reach 52's mHealth platform. They then go out into community, collect data from residents in our partner communities. We can use that data then to identify health gaps. We can also drive really targeted engagements. We always work with local health systems. So as part of all the interventions that we run, we're providing referrals to care at publicly financed facilities. And then increasingly, Reach 52 is building a network of partnered retailers as well. So small mom and pop shops, pharmacies in the rural areas that we serve, and using that as a distribution channel to increase access to medicine, consumer health products, these types of things. So I'd love to talk about the model in more detail, but that's not the theme of today's discussion. So looking at markets and impact, as James had mentioned, so Reach 52, our core market originally was in the ASEAN region, being a Singapore headquartered organization. We originally launched our services in Philippines, later expanded to Cambodia, India, Myanmar, Indonesia, and then more recently, within the past couple of years, we have services operating in Kenya and South Africa. In terms of the total impact that we've achieved so far, we've engaged about 1.5 million residents through these digitally enabled agent engagements. So going out into communities, working with agents, or working with residents one-on-one, face-to-face. And we've upskilled about 14,000 community health workers who are serving as Reach 52 agents. When we think about what is an ideal Reach 52 market, we're really looking for countries where there's a minimum of 25 million people in what we call the missing middle. So these aren't necessarily people who are at the base of the economic pyramid, but rather people with a little bit of financial means to pay out of pocket for health services, but who are poorly served by current options in their rural and remote communities. And so that's what we really look at when we're choosing markets for expansion. So let's turn to Reach 52's financial history, and I'll walk you through a bit of our journey here. So we've been around since 2016. Our founder bootstrapped Reach 52 with his own finances. He really believed in the vision and sunk his entire life savings into Reach 52. It took almost 2 years for Reach 52 to get our first contract. And let me actually go back at one step here. So you'll see that Reach 52 works a lot with pharma, consumer health, fast-moving consumer goods firms. And so that's really where the bulk of Reach 52's revenue is coming from. And I'll talk about that in a little bit more detail as I go through this. So our first contract was with Novartis Social Business, helping to support the launch of their access portfolio. Reach 52 offers services like patient engagement, like brand awareness, like insights and data, as well as product distribution as well. In 2019, we closed our seed round, about $500,000. This was with a non-impact investor, a traditional financer. We then took on, over the next year and a half, about $1 million in debt financing. And we were lucky to do that right before COVID hit. Now, as we look towards the present, Reach 52 is projecting break even in 2023, which we're extremely excited about. But throughout the course of this journey, it's really, as James talked about briefly, a mix of financial instruments that have supported Reach 52. So we have our core business, but we're also an organization that has received grants throughout the course of our history. We're getting, as I mentioned, debt, or we have taken on debt, as well as equity investment as well. So what are the financial challenges? I mean, we could talk about this all day. I'm sure there are no shortage of financial challenges for both Reach 52 and all of the organizations, I think, that have presented today. We know that there's a huge finance gap when it comes to global health in general. A lot of the funding is tied to specific verticals as well, whereas Reach 52 works across the entire health spectrum, focusing on access to primary care. Thinking about some of the internal financial challenges with our model, there's a low willingness to pay. A lot of our residents that we work with are very price sensitive. The unit economics are incredibly challenging. You know, we're moving products that are worth less than $1 in some really challenging environments. So to get that working in a way that's attractive to residents, as well as profitable for Reach 52 is really, can be quite difficult. And then if we look at sort of strategic investments, Reach 52 has multiple revenue streams. So we're generating revenue from our B2B clients in, as I mentioned, the pharma, consumer health sectors. We also have B2C revenue from our partnered merchants. But there's really a preference from investors to have a more streamlined, simplified business model. For us, we found that it just doesn't work. We need a variety of revenue channels in order to make ourselves financially sustainable and feasible. There's also a preference for pure tech models. I mean, we are a health tech social enterprise, but it's a very high touch model that we operate. You know, we're working through networks of, as I said, thousands of community health workers. And so there's often a preference to go for models that are purely digital, that perhaps are lower touch. And I would echo some of the earlier comments as well. I mean, the due diligence requirements are often onerous. You know, we'll go through discussions with potential funders that extend, you know, year plus through the due diligence process, only to find perhaps later on that it's not a good fit, it doesn't work out for whatever reason. And so, you know, I appreciate the requirements or the need for a smooth due diligence, but of course, looking to shorten that interval would be preferable for Reach 52. So what's our future vision? Just wrapping up on this slide here. We're really looking to improve our business and integrate health financing as a core part of our business. We're really excited to be working on an innovative financial instrument, a revolving fund that Reach 52 is looking to roll out with some of our partners. This would see a portion of Reach 52's profit put back into this revolving fund that can then be used for upskilling community health workers and for addressing underfinanced needs in the health sector. Once we've done this, we're really looking to just grow organically as we have been for the last number of years, and then raise investment once we've proven the model and actually shown that it's something to be emulated. So that's everything that I wanted to cover today. I'd love to hear from you. My email address is there. Feel free to reach out to me. Thanks so much for your time today.
Thanks. Thanks so much, Roger. All right, stand up. Just stand up. We'll all feel better if you do it. And then we'll go on to our panel discussion, and maybe our panelists could come on and go ahead and take seats up here after you sit. Anywhere is fine. Yeah, where you're comfortable. Charlene? Peter? All right, you got a little bit of energy. We'll keep on going. So we are on time, and we've allocated about 45 minutes for this discussion right now. And I've kind of already laid the groundwork. What I haven't done is to introduce our panel. First of all, we were so grateful that all of you said yes to being here and joining us on this discussion. The diversity that's represented by your respective positions is outstanding, and I think is going to make for a really great discussion. I wrote these really great little bios based on what they provided me, but if I read them to you, we're going to take up too much time. So I'm not going to do that right now. They're all stunning professionals, and let me just go real briefly. Carolina Batista, with head of Global Health Affairs at Baraka. Of course, you've already met. Peter Beyer, Deputy Executive Director for the Global Antibiotic and Research Development Partnership, or GARD-P. Stefan Wilhelm, Director, Social Impact, Public Affairs, Science, and Sustainability at the Bayer Foundation. Andrea Fego, Luisa Bernal, sorry, with the UNDP Sustainable Finance Hub in Geneva, and we've worked a long time now with Luisa. And Andrea Fego, CEO and founder of the Health Finance Institute. And Hector Portale, the Executive Director of the Movement Health Foundation. So as we go through the discussion, I think you're going to see some of the variety of perspectives based on the programming that they're all doing. Can you take that?
Yeah.
Thank you. Am I mic'd or am I not mic'd? Now, am I mic'd? Okay, great. Sorry about that. So we've broken this into 3 sections, and I wanted to start with what's getting funded, what's working, why is it getting funded, and what are the vehicles that the funding is coming through in a really broad swipe, and all of these individuals are directly engaged as professionals on behalf of their organizations in this work, so can comment authoritatively there. And I think there's a couple places to start. I think, Luisa, I might actually start with you and with the UNDP. A rather unique flavor of what's out there in terms of funding important health gaps is the social impact bond. And you've recently set up the tobacco control social impact bond with a lot of specificity around it. And I thought it'd be really interesting for the crowd if you could just briefly overview that program. Oh, sorry, there we go.
Yeah, thank you so much. So a pleasure to be here. And yes, UNDP, we are working across 170 countries and territories, working with developing countries, looking at financing in a very comprehensive way and trying to link better financing to development needs and development priorities and the Sustainable Development Goals. And as we do that, we are, of course, looking at what are the innovative mechanisms that we can mobilize to the private sector capacities, not only finance, but also expertise and the data, technologies that they can bring. So in this particular case, working with partners, a number of organizations, international organizations like FAO, government departments, also international, the World Health Organization, etc. So we identified the Tobacco Control Sustainability Impact Bond as a possibility to help, in this case, Zambia, to actually meet the commitments of the convention to reduce the hectares or the production of tobacco. So why do we think that the Sustainability Impact Bond is a good idea? Basically because for this kind of alternative livelihood processes to be successful, you need a very comprehensive kind of approach. It's not only about substituting one crop for the other, but it's really about giving opportunities and a number of services to farmers to find a livelihood that may incorporate another crop or also all farms activities. So there is a requirement for agricultural extension, for training, for credit, for insurance. So a number of actors need to intervene, and also a significant amount of capital needs to be put upfront for that to work. So we have done the work in Zambia, a lot of research working with the government, with the different partners, looking at the feasibility and gathering the data, and we believe that we are able to do that. And the government is behind the data that we have come up with. And basically, we had also an impact investor interested to contribute and allow the service providers to work with the farmers and others to transition. What we don't have yet is an outcome payer. The government of Zambia is unable to do that, even if he believes and he would like to go ahead with this process. And of course, we are doing this in a context, as we know, which is very critical for developing countries. We are in we are in the middle of a debt crisis. Zambia actually already defaulted in its sovereign debt. So that is the context. So the government doesn't have the capacity, even if it would like to commit to this, to the upfront payment as an outcome payer to pay in 7 years later, right? So we need to mobilize the private investors and an outcome payer, maybe a foundation and others that could make this happen. The data, of course, is critical to be able to prove that the results have been achieved and be able then to pay investors. And we have that data, so we have all what is required. We were looking at either hectares that has been withdrawn from tobacco production, as well as the number of farmers that have transitioned to the livelihood. This will be the immediate data that we can collect, of course, and we can estimate. And there are other benefits or outcomes that we are confident that we could measure in the middle long run. So the increased revenue or resources for the family, improve health for the farmers themselves, because cultivating tobacco is problematic for their own health, better result for the community in terms of access to education for the kids, because there is improved revenue in the household. So there are a number of benefits that we know as the program goes on, we will be able also to measure. Challenges, of course, is complex. It's complex in terms of the number of partnerships that are required, complex implementing. There are a number of service providers that will be there. There will, of course, we need verification. There will need to be the convener. So there are a lot of complexities in the financial instrument itself and in producing the outcomes in the field. But we are confident that this is doable. We know that alternative livelihoods experiences have happened successfully in other countries supported by the UN and others, in Bangladesh, in Brazil, in Zambia itself, a number of programs. So we are confident that this could happen. We just need the scale, because actually FAO, ILO, World Health Organization, there are a number of initiatives trying to do this, but not at the scale that we need. So we believe that the social impact bond could be a way to bring all these actors together and have something more meaningful. We believe that 50% of the hectares of tobacco would be one outcome. So 50% less hectares of tobacco cultivation and 50% less farmers working in tobacco in Zambia. Thank you.
Thank you, Luisa. You know, so you'll see here we have kind of a whole spectrum, and it's probably not comprehensive enough, of the different types of financial vehicles that we know are being deployed today. And another thing I need to tell you, when I do these programs, I do it improvisationally, so none of them know who I'm going to call on next. It's not very fair to them, but it makes it interesting. And so, Andrea, I'd really like you to kind of go off of some of the, because I know you work a lot on outcomes-based payment structures and have probably a lot to kind of add to Luisa's comments.
I do have a lot to add, but then I would have to throw out the speech that I wrote for today.
Sorry.
And secondly, first of all, I want to thank Baraka for inviting HFI as a co-host for this event. And, you know, James, when you said Friday evening, you know, talk about finance, and I was like, okay, well, everybody's interested in financing because it is the most important conversation. So we're probably going to have half the room full. But boy, you know, if we had that event on Monday or Tuesday, people would have been fighting over space.
True.
So very strategic. So. So at the Health Finance Institute, we do work on two things really, and one is looking at data and impact measurement for health and how to utilize that data to then de-risk investments primarily focused on a blended finance space, which social impact bonds occupy. But as much as that is important, the solutions need to be commensurate with the actual problem. So the problems that we're looking at is that in emerging and high-income economies alike, we're losing each year about 5% GDP because we underinvest in access, adherence, and prevention just for chronic diseases alone. And if you include infectious diseases, that number is higher. Now, that sounds very big, so how big is that number? That is the exact number that was written off balance sheets in 2008 during the financial crisis. right? So we are basically accepting that we live in a second best solution space every single year because we don't finance what we know works. So why are we so complacent and are accepting the second best solution space as our reality? So one of the reasons is that we say we need to make sure everybody understands where we are and how we can get into a better solution space. So that we need to harness the potential of the shared value space between health and wealth. And therefore we need data that detail health and economic and financial impacts are critical. So we also need to understand who benefits and who pays. You cannot have only investors for impact bonds, you need outcome payers. So, which is absolutely critical. And so we think that there's a really, so we're at a tipping point, and that the time for better data and metrics is now, because the IMF, so when you look at the World Bank meetings that happened in the spring, nobody talked about health. But the IMF talked about health because it said it's a macro critical investment, which means it's not just generating returns if you invest in the health sector, but if you actually invest beyond. Like invest, you actually yield returns beyond the healthcare sector. So it's macro critical, and there now is a global understanding of this macro criticality of investment in health. So at HFI, the Health Finance Institute, we're working towards accelerating better financial health outcomes, focused decision making. So since 2019, so we are a startup and we are a non-profit startup. So sometimes I think we're very stupid because we're a non-profit startup. So I wouldn't recommend anybody go down that road, but here we are. So I commend all the founders that spoke today. So we've built several global and local partnerships. We focus on a combination of how health, economic, and financial data can make the case for smarter investments in health. So we have, our tools and analyses have been utilized and deployed and changed the course of action and investments in Armenia, South Africa, Nigeria, Cambodia, and over 40 sub-Saharan African countries. And in Mexico, we also helped establish a public-private partnerships and negotiated down the price of continuous glucose monitors by 80%. And after this week, what's really exciting is the coalition around a revolving fund to provide access to these devices in Mexico if everything goes well. We also found again that there's a huge benefit of these interventions that we evaluate, like where you have double or triple or quadruple the returns of your investment, for example, in diabetes projects in Armenia. So we're also working with Reach 52. We're looking at the economic impact of their model in Cambodia. That's a joint project with Sanofi. And we're actually taking that to actually probably the next level with City Cancer Challenge, which just left. So really we're thinking about how can we utilize data that then de-risk future both public and private investments. So as James has mentioned, the fiscal space in the public and the donor sector is contracting in global health. And so unless we harness private capital in the best possible way, we're not going to reach UHC by 2030, and we're not going to reach UHC by 2040, and we're not going to reach UHC ever. So we really need to figure out how to finance health and use that financing that is on the table in a very good way. So the next thing that we're doing is we are starting a we're starting a company called the Health Equity Score. And the concept is very simple. We're going to create a health credit, the same way that a carbon credit exists. So McDonald's can buy health impact credits from Reach 52. So if you want to, I know I've taken a lot of air. There's more to say on data, and yeah, I think that unless we start to internalize the value that health creates, or companies or health, projects create into companies' bottom lines and into investment vehicles, we will stay in that second best solution space.
Thank you. Perfect, Andrea. Thanks. Let me pivot and ask you, Stefan, to speak a little bit about another aspiration that many organizations have with varying levels of success, something that Baraka ourselves are regularly involved in, and that is the idea of concessionary or catalytic capital. to leverage additional funding. I think all of our founders have been recipients of such. You deploy such on behalf of Bear Foundation, but in conversations you've admitted the challenges that exist in this approach. So we're somewhere else here on the spectrum of vehicles, but I'd like to go to that next. Can you talk a little bit about how that's working for Bear? Sorry, there you go.
Sure. So first of all, again, thanks for having me, and kudos to these guys, because it's you that it's all about, right?
Yeah.
Not us. I think that's the first thing we always need to highlight. Yes, finance is a means to an end, but money is never an end in and of itself. So that's what it's all about, and we need to get our act together, which we don't, which, Andrea, you just highlighted in a very, very comprehensive way. And I think, yeah, I mean, I could go on and on about the challenges that you have uniting capital. What does it mean to be catalytic, right? I mean, just start with being a foundation versus being an investor versus being an impact investor versus being all of that. I think you can just, if we want to make it work, we can just cut all of that and kind of a little bit like donut economics, like focus on what can be inside our planetary boundaries. And for me, and also strategically for us, it's the complementarity aspect of it. So if you look at philanthropic capital from an impact investor or investing perspective, you could also look at it as 100% risk capital, right? So either you de-risk an investment in a company like Abby's, for example, or you provide a sandbox for experimentation that then can make models work that you know and trust will work, but that nobody wants to invest in because it's too high risk. And then the next thing is, if you have this trust and you have a larger network of organizations, and you have somebody like UNDP, for example, who'll come in, or Gavi here in the audience, that will make a connection to the government and say, look, this is a trusted solution. We have tested this. We have tried. Now we can scale it. Because I think one very important aspect here is also to be honest and candid and realistic about what you can do. I think we all want to brag about how much we do. And I mean, I could parade Abby and Daisy around all day and say, like, look, they won our Women Empowerment Award. Yes, they did, and rightly so. But that's not the point. The point is that Abby received this award and after got on a stage where it was recognized that her model works. And now she's attracting capital. And still, it's eternally difficult, to be at the other side of the table. Because even if you're at the World Health Assembly, you run around after people who have money, asking them for money. It should be the other way around. We need to run after the solutions and give them the money that they need in the way that they need it, right? So, at least for me, that's what catalytic means. But to understand that, we all need to kind of lower our guard and actually collaborate. I mean, my image that I always convey is we all sit in silos waving a collaboration flag out the top, right? So, you better get out your iron saw and the hammer and break down the silo to reach out with the hand and say, like, look, because it is complementary. That's something that we really learned. We have so many challenges. I'm not going to go into the technicalities of German tax law. 99% of global literature on tax is in German just because of that. So it's not easy. But at the same time, there's always a workaround. Somebody at the World Health Assembly said, somebody much smarter than me, if the system doesn't support the solution, then you need to defy the system and work around it. So if you reach out and identify the complementarities in communities of practice, in these rounds, like unlikely partnerships can work. It can work, because we cannot invest, because we're not an investor, we're a foundation, so we give away money, but we want to support self-sustaining, scalable solution, which others also do, so we can de-risk the investment or, fund like an exploratory study for a market expansion or something like that, and then in the community, you find others who can give technical assistance, concessional loans, debt, equity investment, and so on and so forth. So this, for me, is catalytic. And catalytic is not us giving catalytic funding, it's the community being catalytic to serve those guys. And that's, for me, what it's about.
Yeah, excellent. And actually, outside the scope of just your own work, to talk about the ecosystem largely and that whole concept of collaboration, which we'll spend a little bit more time on. I'm watching time. So I'm going to pivot us into some of the data conversation at this point. It is a drumbeat, and I'm sure everybody in this room is familiar with that drumbeat about the need for more data and what we've done. Thank you. There's more ways we could slice and dice this, but certainly market contextualizing data. What is the environment? What are the externalities? What are the peripheral information that supports or undermines an investment's wisdom? And then the health impact data specifically. And both of these are elusive and disaggregated at the moment. So there are a variety of ways that I think organizations are getting at this. Hector, you always speak quite eloquently about this, and Movement Health Foundation's perspective on the role of data to drive your own mission. And if you don't mind, just take a minute and tell the group what your foundation is up to and how data fits into that. Oh, sorry, Mike. Yeah, I keep forgetting about that part. Here you go. There you go.
Thank you, everyone, for being together today to really see how we can take action on bridging this gap. And Movement Health supports global health systems and local ecosystems to assist in the transition of the increasing burden of chronic diseases, mainly by supporting scalable, innovative solutions that are locally owned, and that's the key for their sustainability, that they answer to the local problems with a local understanding of what's a priority and what's as well the financial mechanisms to make them sustainable in the current operative models, so that then we can generate new value. And perhaps that's where Movement Health is focusing, if I may say it in 3 letters, on fit, on closing the gaps, because we see the fit. And that fit has 3 key instruments. The first one is the financial mechanisms. We have been seeing in Brazil how Brazil, together with the World Bank, has really provided a mechanisms to incorporate through the Innovation Open Challenge mechanism ways of using in the public healthcare sector innovative solutions that otherwise would have been impossible because of the tendering processes. And we can see here, right, in the entrepreneur sector, how hard it may be to cope up with all those mechanisms. And most importantly, that perhaps the fit for the real need is not there, when rather by working with the solutions, we may identify which are the right points to tackle and adapt or customize the solutions to the real need. The second letter is incentives, because we do see how important it is to be aligned on the incentives and to connect with the real priorities that the healthcare providers do need to tackle in order to make those systems more sustainable and viable in the incorporation of those solutions. And that's what, with Movement Health and our local partners in Chile, have been seeing. When there's a problem for more than 20 years on increasing waiting lists that have spiked to a 500% during COVID. And we gather a group of experts to see what we can do about it. We work with the National Thorax Institute, which was the most burdened institution in the country at that time. And we identify that interoperability, which was an enormous market opportunity to as well start transforming the healthcare sector and create the ecosystem for all the digital tools, was not there. So in order to generate the ecosystem predisposition to start implementing new solutions, we started working on raising the awareness on how important interoperability was with the right incentive, which was decreasing the waiting lists. Those experts raised a manifesto where we identified that there were several things to be done, that the local government in elections, the different candidates adopted as their campaign mechanisms. And we are working with the current government thanks to the local partners. And really I want to stress, Stefan, how important it is to let the ones that are the experts do the job and really build the long-lasting, sustainable relationships where health happens, which is in the local level. And they are working now with the Ministry of Health, who has created a whole interoperability sector so that we can start thinking on having the right data to decide upon at a national level. They have a commission that oversees with the public society the evolution of these implementations, and they are currently running 2 implementations there. And last, it's the T, which comes to trust. We need to find, as you were mentioning, even though if the sandbox mechanisms are quite innovative in the emerging economies, the ways in which our decision makers and the major healthcare providers can raise the appetite for the solutions that will really tackle the burden of diseases that we are facing right now. And it was in Colombia where we were working with an ecosystem of 6 solutions in 7 hospitals, where in the work to customize their complementarity to tackle the local needs, at one point, the major implementers, we have 2 of the major clinics in the country working with us, realized that they were making an enormous effort to build in-house patient monitoring systems. And they say, listen, let's find the viable mechanism model so that instead of doing it in-house, I can outsource this to you because, that's not my core. I'm wasting a lot of energy trying to do it, and really it's taking me out of, managing what I'm best at. So if we want to have more appetite, and this is something that we can take action upon today here, those who are engaged, is by raising the awareness of the cost of inaction. CDC forecasted a 6 trillion loss after Ebola for the next pandemic. And the G20 just mentioned that it was 22 trillion and still counting. So when we do see the cost of inaction and the cost of opportunity, that from a political perspective will come to a critical standpoint, because people are losing, when the health systems are not responsive, the trust in our institutions. And therefore, it's a critical investment opportunity on the welfare of our societies to start thinking on how connecting with the real needs, the digital transformations that these fantastic entrepreneurs are running in the countries where lives are being saved.
Thanks, Hector. I'd like to hear from Gardpi. I'd like to hear from Peter. And we talked about a couple of different places where Gardpi's experience, dovetails with conversations that have already been here. I think this Shinogi partnership is a fascinating story. And if you're willing to tell that in its broadest form, that would be great.
Wonderful, James. Thank you so much for having me. I think you said at the beginning, we need to have the private capital blended financing, and that's exactly what we do. We have a foundation here in Geneva, GARDP. We do antibiotic drug development and access to antibiotics. Unfortunately, an area which has become increasingly unattractive for the pharmaceutical industry, because it is a high-risk investment, and at the end, you're going to make very little money with these new antibiotics. Not because they are not needed, they are needed, but they are reserve antibiotics, they are kept on the shelf, they are only used for really drug-resistant infections, and a lot of this disease burden is concentrated in low and middle income countries where the purchasing power is lower. So that is why we are a foundation financed by governments, and we do invest in drug development projects, and we want to bring these antibiotics actually to the patients who need them most. And there are 2 interesting projects. You mentioned one. We have from Shionogi, a Japanese company, was very generous. They licensed us their new breakthrough antibiotic, which is particularly useful for hospital-acquired infections. And we have the license for 135 countries, basically all Latin America, all Africa, Southeast Asia. So we have really the key countries where the disease burden is. And now we have identified in a competitive process an adequate manufacturer, fantastic company sitting in a low and middle income country. We are basically the matchmaker between the Japanese originator and the generic manufacturer. They met for the first time this week here in Geneva. I would say they fell in love. And it was wonderful to see, it's across cultures. But I mean, you also have to bring something into the marriage, and we have the license, 135 countries. Of course, these are the countries where basically you may actually make a small margin. You make a loss. You need to have a low price to actually break through and bring this drug to the patients. And the manufacturing process is relatively challenging. It's a complicated process. We can do tech transfer, but we need an investment, and that is where I think the blended financing comes in. And we can do, of course, a little bit of it. They will put their own money, they will attract some other private investors, but we need people like Stefan and others to come in to hopefully run after us. I love this. If the people would run after us to give us money, I would basically be out of a job. But that is one thing, and it's really, it's not a high-risk investment because the drug works. It's used in Germany, in Switzerland, elsewhere. It is super important, for example, for the Ukraine conflict, other countries in conflict, because it's active against these all drug-resistant infections you pick up through these war-inflicted wounds. So a small investment, not high risk and critical. We will treat patients in 2-3 years, and you can actually show return on investment on a a health impact investment. And the other point, the other project we work on is much higher risk. That is why we want to do it. Is a key molecule which works against one of the worst gram-negative bacteria, Acinetobacter, which is actually responsible for many of these deadly drug-resistant infections you can pick up in hospitals. It's at early stage. The company has raised private capital. They have pushed it to a level where we still have to work on the formulation. We have to start the clinical trials in humans. And Big Pharma is interested, but Big Pharma is sitting actually on the sidelines because they want others to further de-risk the investment before they step in. And that is where we are and where we need actually some more investment coming to us that we can invest in the company. We will bring the necessary expertise to look at the formulation, de-risk the product, and push it to the next level when Big Pharma comes in and takes it over. We don't take equity in the company. We don't take a board seat. So what we do is perfectly viable for a private investor because we take the license again for the low and middle income countries where Big Pharma is not going to make a lot of money anyway. So it's a win-win situation. They can still take equity. They get the European market, US, Japan, Australia, where, hopefully they can make a return on investment. So that, of course, is high risk. When we evaluate the risk of this compound to ever come to the patient, well, it's between 10 and 20%. So that is why you need actually public funding or philanthropic funding to de-risk the investment.
So I want to go just minorly off script and talk about, you basically have found a formula that seems to have an appeal to a number of private sector investors. At Baraka, we're working really hard to find formulas that will do exactly that. We believe market context plus health impact has to be increased so that an investor can understand. I often tell people I feel like I'm carrying 2 buckets of water uphill. One of them is emerging market opportunity and the risk perception associated with that. And the other bucket is the complexity of the health sector, because it's complex. And if you do it cross-border, it gets more complex. I'd like each of you to tell me what you think we could do to accelerate mainstream investor understanding, sympathy and then engagement, or empathy and then engagement. Just top of mind. Go ahead, Hector. Oh, I'm sorry. I keep on not passing this along. Here you go. You can share this. I'm sorry.
I do first see a great opportunity of how we may convey the notion of the cost of inaction, right? When we are seeing now in the current context as well, there are some countries close in the border where the conflict with the Russia-initiated conflict is, that have decided in very short amounts of time to start building the infrastructure of digital health saving registries because of the sense of urgency of ensuring that we can have long-term safe ways of keeping the information of our populations. So definitely there's a strong point to really ensure that we have the right sense of urgency on which are the priorities to start building the infrastructure for tomorrow. And that's an opportunity that we may have on see how directly linked is the digital transformation on health systems to achieving the Sustainable Development Goals of saving, 1/3 more of preventable deaths.
Andrea?
I think the part of the answer is actually already up here. You have market context and health impact, and we need to show again and again how these do correlate and how health impact actually drives market returns. And I think the impact dashboard that you have at Baraka is a fantastic step in the right direction. And we need to really get it out there and, have more of those conversations. So, health impact can be part of the S in ESG, it can be part of due diligence formula for VCs, and so on and so forth. But we have to make that mainstream for investors.
That's great. So the again and again and again part is really important. And all of you here today need to know that when you're out there doing whatever it is you do within this sector, it's the repetition that wider audiences need to hear. Luisa.
Yeah, I think from our perspective, I think we need to get better at communicating and educating about the importance of investing in public goods, whether it's climate change, whether it's about global health and prevention, etc. We need to do that. That's probably you're not surprised from me coming from the UN, but we need to see the value of actually all of us contributing to that collectively. And I think, yes, information data, there are a lot of biases. We feel that the financial system, the architecture is not working for developing countries. And you can see from credit rating agencies, for example, in Africa, it's so unfair. So a lot of the cost of borrowing right now for countries in Africa is really not related to the fundamentals of their economies. So some issues like that, educating data and repeating and coming back with facts so that we can at least put things correct and make the right decision. Thank you.
I would like to make it a little bit more concrete and just really going into Peter's example from just now. So there's obviously a collective interest in making for new formulas or multi-resistant drugs against multi-resistant diseases available to those who are in need of it. And there's already an infrastructure that does this on a different level. Like there's product donations from all major pharma companies to the WHO, for example. We have this, like it's worth billions of dollars every year. There are multi-year, like decades of contracts that have been going on. So question is, why isn't there a market incentive being pushed through those partnerships, for example? Because for big pharma, it's about the margins, like you said. Of course, we have I think the key word here is the difference between the prices in the different markets. Why does everybody want to go to the US? Yes, because it pays the most money for drugs. You have the highest margin. That's the only reason. It's that we don't need to be complicated about finance. More money, less money. That's it. So, I mean, the solution is the same. People just can't pay. We still do that, and I mean, it's understandable. We live in a market-driven economy, so it's not an argument against it. But you could say, why don't we use this vehicle? And the only way that you can make it viable in terms of market is scale. So that's what you were talking about. I mean, there are basically billions of recipients for these solutions. Again, if you make it complementary and if you make big pharmaceutical companies work together, because they do this. I mean, there are a lot of drugs that are marketed together by different pharmaceutical companies in different markets, sometimes in the same markets. You just need to translate the mechanism into those markets that aren't as attractive. Most pharma companies just don't have products also for this market, right? So it just doesn't really exist, but the market is there. And how can you verify this? Or how can you make this more attractive for large pharma, for example? The ATM index, Access to Medicine Index, that's something that has the potential to move the needle on the stock price of companies. So if you're 20 out of 20 in the ATM index, you suck, right? So how do you make it better? You make drugs available for people, you support innovative business models that get the medicine to the people that need it. So I'm not sure that we don't have the solution, it's just not being accelerated. So why, the question I think we should be asking is why? So it's like you said, there are solutions there that already exist. So how do you incentivize it, and how, maybe it's political pressure. Why doesn't the WHO result, why isn't the result from this week, hey, here we have an agreement between, I don't know, governments and pharmaceutical companies that are going to give this to, I don't know, 1 billion people in the next 5 years. Where is it, right? So I don't think the solution isn't there. I just think that we need to be less arrogant and kind of really lower our guard and work together. And of course, the again and again part is probably the most important here. But I think this community here in the room, in this particular city, can definitely move a little bit forward. And there are a lot of representatives from those countries, companies inside those companies that agree and want to do the same thing. So, we just have to keep trying, I guess.
That last comment is fascinating. I have had my own learning curve since we've started Baraka about 3 years ago now, on the number of individuals within the large pharma and medical device companies who see another way, who see the importance of reallocation of some of their emphasis. There are a lot of individuals. It's really true. Peter, do you want to comment further on this?
Yeah, I have two comments, and I mean, you mentioned it. I mean, why the pharmaceutical companies are not investing? Because there are comparable investments where they come to a market for chronic disease in the US, where they just make so much more money. So I mean, of course, from financial perspective, they would probably be liable to the shareholders if they would actually invest in antibiotics. Shareholders don't, I mean, that's it. And I think what you said is also interesting. We don't like to consider patients as a market. But if you think that in South Asia, our colleague Jennifer came up with a number that out of a 1.5 million carbapenem-resistant infections, only 40,000 are treated with the antibiotic that is actually working against this resistant mechanism. That is an enormous market. And our generic manufacturer, hopefully, is going to have actually a return on investment by serving these patients this product at a low price, but in bigger volumes. And that is something where we want to create our products. We ideally want to have a sustainable model where there's a company who is producing quality generic products and can actually sell them at an affordable price and also make a revenue. And that, because that is the ideal situation where actually the private market is actually driving access. The one thing you asked about the health impact investors, and you mentioned it, when you go to banks and you waste your time, and because in the end they want 40% interest rates in 1 year. I mean, my experience is even the big development banks, they are super risk adverse. They don't want to lose money and they want return on investment. I mean, why are they called development banks sometimes? That is what I don't understand. And that is really, whoever wants to really say that they do health impact investment, they have to be ready to really lose 100% of their investment, at best get it back, I mean, with 0 interest rates. I mean, that is health impact investment. I mean,
all the time.
Yeah.
8 out of 10 startups fail, right?
Yes.
Carolina, do you want to add comments here?
No, I'll add, and I think thank you all, and really thank you, Daisy, Abby, Logan, and Guillermo. I think you really brought what we needed for the beginning of the session. I think we oftentimes talk so much about the financial mechanisms and the vehicles and the need to new financial frames, but we have to always remember why we're talking about it, and I think that has to do with Stefan said also. It's about the patients you serve, right? It's about and really amazing journey. You all like bootstrapping and working as female entrepreneurs even more, right? Like sometimes you have so many other things, and maybe at the I've presented in the beginning of the session about our health investment intelligence dashboard, and I think the words that comes to me in this session is really partnership. And it's collaboration. And yesterday I was in a session at the Intercontinental, and there was a representative from the Kenyan Minister of Health, and she said, Africa doesn't need charity. Africa needs partnership. And I think, this is what it's all about. I think it's about partnering, and it's about partnering in the right sense. And I think that also has to do with, yes, if you're a bank, but then for the rich, you don't charge so much interest. And then for the poor, or for those who want to be innovative, you're charging so much. You're creating a barrier that's impossible. So how to create partnerships that are in the same level and also equals the types of people you're dealing with, and not really putting like a bad brand on things. And your models are working. So I think the fact that we always have to think, and maybe for me being a physician, I always try to think, how does this impact patients, right? Because that's what I did in my life, and that's what I intend to keep doing in my life, is really identifying people like you guys, so that patients who unfortunately I might have lost in the past because there were no solutions in place, they could benefit. So I think thinking about that, and then I think also it's after this full week of meetings, I think one thing it's clear, we need to change the global health architecture, and I think the financing mechanisms and the money that will be like the cement of this new architecture, of this new building of global health architecture. And I think, again, the market contextualization, I think it's important. You cannot compare, I don't know, vaccinating or delivering a drug for a child in Geneva and delivering that in the rural areas of Nigeria or in Brazil, where I come from. So market contextualization is really important, and that's what we're trying to do with the tool that we're building with our partners. The Health Investment Intelligence Dashboard is really to contextualize that and show that these are the contexts we're working with, these are the needs of the people, and these are the types of indicators that we're using to make sure that people understand, like how long it takes to go to a health center, how many people are being pushed into poverty because they cannot afford to be sick, and all of that. So I think contextualizing and really making sure that people understand what we're talking about. But then really, and I think the last link of this very important chain is supporting guys like you, because as I always say, these solutions that will address markets like where you guys are working, where I come from, will not most likely come from the Silicon Valley. Will come from brains and hearts like yours. So I think it's really, for me, that's the key message here. Thank you.
Great. So I'm gonna wind us up here, but I want to do it with another question that goes into partnerships. And put you all on the spot a bit about the partnerships that are necessary to accelerate the financing processes that these entrepreneurs go through. Because the stories that they all told about how long it is, how challenging it is, how there's no correlation between the amount of time you spend and the amount of capital you finally raise, this is a huge problem. We hear it again and again and again. So to the degree that you're able, what are the partnerships, what are the collaborations we need to do in order to minimize that impact, that timeline? And anyone who wants to jump in, think outside the box. Oh, sorry, gosh, me and the mic. Yeah, I'll just leave the mic here.
Yeah, I mean, again, it's the complementarity aspect, I think, because and it depends also on the size of the organization. If you work with a big bank, of course, or a development bank, of course, they have large, long processes, large foundations also. Even if they're able to impact invest, they will take a long time. Take Bill and Melinda Gates, for example, it's going to take up to a year until the disbursement happens. And then you first you need to write the application, right? So that takes another kind of 6 months. You can have different players in the ecosystem that are leaner and smaller, that can, for example, front load a grant to make something happen. Then you have a track record and a result, and then you can build on that result and argue. First of all, you can have an agreement, at least an MOU or some kind of statement where it says, okay, we promise that we're going to pay, basically, and then you can go in, and this is what we did in a couple of examples, and we just go high risk and pay out 80% of a grant, for example, up front, because then it happens, because otherwise these projects die. I mean, it just doesn't happen. And then if you're successful, of course it can go south, but if you're successful, you don't only have a promise of somebody who pays and will then put more money in, maybe even an investment, but you also have a reference point of result of impact that you have already generated that will hopefully then attract other players from different sectors to put money and resources on top.
Yeah,
so I think that's
great.
Something to do.
Hector.
An opportunity is what we are doing in Movement Health, where we are gathering complementary partners on their expertise that want to work on the decision makers' priority at a local level, where we are working with our funders, being Microsoft, Siemens Healthineers, Roche, the Copenhagen Institute for Future Studies, to be at the disposal of the needs of the local health systems in the countries where we need, to start building the right platforms, to customize the viability models to their needs, to the local scalability potential. And that's where we have been in conversations and providing the right frameworks to start those implementations that then may connect with the real investment incentives, the real priorities of the local stakeholders to bring that models that can be fit to the acquisition mechanisms of health systems, right? We need to understand which are the healthcare sector investment capacities. You know, sometimes they may have all the willingness of the world. We have been seeing this in Chile, in the National Thorax Institute. But then the contracting mechanism is divided in multiple national or regional sources. So if we have the possibility to be together with implementers while finding which is the specific purchasing mechanism for that solutions, then we can help the solutions transition the valley and really have the right model to achieve scalability.
Yeah, I think it's important you didn't get a chance to say, because it was just this week that you announced your new partnership with Microsoft, with Siemens, and with the Copenhagen Institute for the Future. And so it really is an ecosystem approach that, of course, we wish you the very best on. Excellent. Andrea, you want to jump in on that topic?
Sure. I think on that topic, I take away two things from this week. And one is that political will isn't enough. We need political commitment when it comes to blended finance. So it's not enough to say, okay, there's policymakers who want to do something. We need policymakers that step in for, larger blended finance mechanisms. And the second thing is that it's not enough to care. You actually need to resource what you care. So we need to resource what we care about. And a footnote to these two takeaways is that you cannot leverage or catalyze something unless you actually have ingredients and a reaction to go, which means you have to have capital on the table or resources on the table from all partners. So catalysis, like I came from biochemistry, it doesn't if there's no ingredients to react with each other, aka there's no resources to actually create impact, you can't catalyze anything. So that's absolutely important to understand.
Excellent point. Peter, go ahead, yeah.
You asked about partnerships, and I mentioned the Shionogi partnership, where now we're looking for a manufacturer. But it is also really important to even drive it further. In a market which is as complicated as new antibiotics, we also, as a foundation, engage in making, and bringing this really to the patient and helping the manufacturer, making this a cost-efficient endeavor. Because currently, as a company, you would have to register in all these countries and deliver the drug in very small volumes. That is not cost efficient. It just doesn't work. No company can survive with this model in this market. So what we do now, we partner with the Global Drug Facility for Tuberculosis. They are actually shipping products for TB in 130 countries. They will list our product and make it available. They have a rotating stockpile in the Netherlands. And just to give one example how important it is, we are focusing on antibiotics for children and babies as well, which typically is a small volume. They do that as well. For TB in some countries, there are 5 children treated for multi-drug resistant TB. They ship the product. No company would ever be able to do this and making profit. So they actually buy from the company. So the company has a one-stop shop. They buy the pediatric formulation from the company. They put it in their stockpile in Holland, and they ship it for one child in a specific country. And that is fantastic, and we can do that. And of course, they have investment from USAID, from the Japanese government, I think, and we want to leverage their strengths and actually make it happen so that it's also easier for the company to bring the product to the patients.
Fascinating. Luisa, I want to add on that point?
Yeah, no, very briefly to say that I fully agree in the sense that I don't think we are valuing or the financial system is valuing what matters. So I think we really need to change the way that we create value and how we monetize that in the financial system. So that's one thing. Of course, that's a transformation that takes time, and this is a lot of the advocacy that we are doing as the UN and many other organizations that are here. I also agree. I think the local context needs to be strengthened, and a lot of what we are doing is really working with developing countries at country level on the institutional building, the data, a lot of the contextual data about what are the investment opportunities in developing countries for the SDGs, so that investors can use that as a public good and at least start somewhere. But then building those capacities locally, I think the intermediaries that can eventually be the connectors with an international investors that may come, and what are the reliable partners to develop a program, etc. I think that's really important. And it's many different actors. So it's incubators, accelerators, and it's the banking system needs to be educated, and the data there is not there. So it's very challenging, but I think that those are the big areas. So we need a big transformation in the architecture, but we also need to strengthen the local systems with all actors.
Thank you. Carolina, you want to?
Yeah, maybe on that, I think that's. I'll just build a little bit on that. I think that the local context is very important, but also I think that building a narrative around the return for health investment, right? Health is oftentimes seen as a cost, as a very expensive cost in the budget lines of ministers of health, of many other decision makers, but it is an investment. I mean, in terms of having a healthy community, having a healthy country, and really the time and the energy and the workforce that you will have by having healthier people. So I think it's very important to work on this narrative, but also this narrative should not be coming from any of us, should be always coming from you guys, because you're transforming healthcare there. And I think also, without being biased, but I think also thinking about the healthcare workforce. And I think one transversal line in anything that we do is really engage in the healthcare workforce so that they understand the importance of implementation of new tools. It doesn't matter. You can have like an amazing tool, or you can have an amazing, that was my experience in the past working with neglected disease. You can have the best drug for a disease, but if the drug is on the shelf in the Ministry of Health warehouse, doesn't get to the patient, those billions of investments were all put into trash. So the same thing with this new amazing digital health tools. It's there is a need, an urgent need, to build capacity at the local level for the healthcare workforce to adopt that quickly, efficiently, and that patients are ultimately their needs are addressed. So I think that partnerships in those levels also, and having them as also protagonists, like what do I need as a healthcare provider to better serve the communities that I'm serving. So I think partnerships in many ways, and I think each one of us can bring some potential, but you guys need, and I think this forums like this are very important to show that not only you're doing good, but you're doing really well, right, in terms of financially. So I think that making that story very clear and loud, I think that's also our responsibility.
That's a really great place to end the conversation, and I really want to thank Hector Portale and Andrea Fegel and Luisa Bernal and Stefan Wilhelm and Peter Bayer and my partner in crime, Carolina Batista, for being here and keeping this conversation interesting. So we have quite a lot of food and quite a lot of wine, and so it is Friday night, so there's no excuses. But I have one more piece of business. Rebecca, could you stand up, please? And Robin, would you mind coming forward? Are you here? Yeah, thank you. And Audrey and Talal, please. And those are the ones that are here right now, as well as Sejal, if you don't mind just standing up. So I have to tell you, Baraka Impact Finance is a labor of love. That's what it takes to do what we've been doing. It's not for the money, I'll guarantee you that. And I'm so proud, as I said at the beginning of this session, to work with this group of people. It's amazing commitment and amazing talent. I'm shocked by the excellence on a day in, day out basis. So thank you all for making this happen. We only scratch the surface of the expertise and the resources that these individuals are part of. Please stay around as long as any of you can and enjoy the drink and the food. And thank you very much for coming here on a Friday night at the end of WHA. Absolutely.